out on calls right now, we're going to go ahead and record this. That way you guys can kind of review it a little bit later on your spare time while you're on shift. So we do have a set of skills that we have to do today. One of which your CE for this month is actually BLS CPR, and it's something that I want to get us all together to be able just to go through practicing hands-on skills such as chest compressions and also ventilation. And that's really the down and dirty. I'm going to ask you a few questions, of course, at BLS, just to be sure that you're comfortable with those concepts. And I have no doubt in my head that everybody is going to do extremely well with that. So no worries. But we'll have to figure that out for a later time, possibly whenever you guys are on shift next, if not later on today, depending on your availability. Anyway, so what I'm going to do is I'm going to jump right into the scenario side of things, and we're just going to kind of work through the scenario. And I'm going to pull up pictures so you can kind of review it, look at it, and figure out kind of where you would go and what you would do. It's just like all of our other table talk scenarios. It's still the same way. I'll give you a patient presentation, and you kind of work through what would you do if you were placed in this position. So here's the down dirty. You're dispatched to a 72-year-old male with chest pain. Coming on scene, first responders greet you by a family friend who tells you that something is terribly wrong. He states that they were sitting around watching the football game, and his friends clenched his chest and began to complain of pain in his chest that radiated down his left arm. Uh, when walking into the living room, you find the patient sitting upright on a recliner. From a distance, you see that the patient is of poor presentation. The patient is alert and oriented times four, and grimacing from the pain. He is cool, pale, and diaphoretic. The patient has increased respirations and an absent radial pulse. The patient confirms that all that was stated by the friends, and it also includes that the pain is a 10 out of 10, dull ache, shortness of breath, and also nausea. So, what are some first things you guys want to do with this patient? You have, of course, first responders at your disposal. You also have your partner there with you. So, where would you go? Just give you a second to think about that. Essentially, of course, I think everybody works very well in tangent together as far as the way everything operates. So you know that you're going to go and hopefully utilize either your first responders or your partner to go ahead and grab you a set of vitals. Hopefully, if you do have your dispatch alert you to a chest pain call, you should be already having your cardiac monitor with you as you walk through the door. Essentially, what we're trying to do, guys, of course, with any type of cardiovascular involvement, is that we want to EKG within 2 to 3 minutes of putting our hands on that patient. So turn that sucker on as soon as you walk through the door and go ahead and get those stickers loaded and lay those electrodes to that patient. Okay, and of course with consent, as always with anything. So your set of vitals, guys. Your pulse ox is showing a rate at 42. Your SpO2 is at 72. Your blood pressure is not really picking up on anything. The pupils are equal and reactive. And your 12 lead. Now, when your 12 lead comes up, I'm going to pull up a picture. I'm going to share this picture with you and let you look at it and see what you think is going on with this patient. All right. So here you go. So here's your picture. So give you just a second to bring up what your interpretation is. If you need a second, if I go too fast, to let me know. Pause me, whatever you need to do, and that way you can kind of look over it. All right, so just as with any EKG, we want to start with a baseline, right? We start from the P wave and work our way to the right, right? Is there a P wave? Yeah, there's a P wave. It's kind of a little bit flat, right? It's kind of a little bit hard to determine, but there is a P wave there if you stare at it long enough. You have a QRS complex? Yes, you do. There's a QRS, and there is a preceding T wave behind it, right? We look at the width of all those things, and they all seem to be within the parameters, right? So all that looks good. So this does appear, as far as regularity, seems to be very regular. So we're going to call this a sinus rhythm, at least a sinus rhythm in some sort. So if we marched it out and kind of looked at the rate, and we already know that by pulse ox standards, that we're already in a Brady rhythm, right? So this is going to look like a sinus Brady. A sinus Brady is going to be your baseline rhythm. And of course, the way that your axis deviation, it seems to be pretty much normal left axis, nothing pathological left, nothing crazy could go on there. So then we start digging around and looking for abnormalities as far as, do we see anything that would suggest cardiac involvement? So obviously we do have some significant involvement as far as elevation is concerned, that we get turned on to elevation pretty quick. And just straight off the bat, you can see that your inferior leads 2, 3, and AVF all have significant elevation. So we would definitely consider that mostly the root of this would definitely be the inferior side. But we also got to seek out, is there any type of other involvement? And there seems to be a little bit in your lateral leads. You have just a smidgen worth of elevation in those areas. Now, it's not significant enough to just go ahead and say inferior lateral, but you can definitely tell that is definitely present. And of course, we also want to dig around and see if there's any reciprocal changes as far as that's concerned. We see that V2 is also depressed, and then you dig into your V1 and your AVL leads, and those for sure are definitely depressed too. So we're gonna say this is an inferior STEMI, and that this most definitely is going to be a STEMI, 200%, 200%. Okay. So you got a couple of things going on here, right? You have, not only do you have Brady'd patients, but you also have a STEMI. So we're gonna kind of consider this as, since they don't have a palatable blood pressure, nor do they have a palatable pulse, that this person is definitely going to be in shock. They already have a poor presentation. They look like junk. They also have a cool pill diaphoretic. That all just screams that this person needs to be expedited, right? So without haste, your prerogative should be, let's mosey this person towards the hospital as quick as you can. The other component to this, guys, and of course, it's not our priority to transmit EKGs as far as in comparison to patient treatment, but should also be in the back of our mind. Once we get most of what we're done, or if we have extra hands in the back of the truck, get either yourself or someone else to go and transmit that. The sooner that gets out there to the hospital, the quicker they can go, and the quicker they can go and get their staff prepared for the cath lab. Okay. Sorry about the answer machine. All right, guys. So, what are some interventions you want to throw into it? So, say you are loaded into the ambulance, you're ready to roll. You got your partner, and also an extra hand in the back with a first responder. What are some things that you want to move to do? So just like any of our assessments that we walk through, we're always assessing our ABCs first, right? So essentially, we already know the person has picnic. They also are in shock. Their body is saying screaming shock all over. So we need to go ahead and just give that person some high flow oxygen straight off the bat. Stack that oxygen if you must, right? Get that 15 liters on them, and if you need to, nasal cannula 15 liters. I mean, they got a poor SpO2 anyways, but being that they're in shock, period, that warrants oxygen therapy. So lay it to them, give that to them. What are some secondary things you want to work beyond that? Of course, you want to get the ASA on there as quick as you can. So go and get your 324 ASA down the hatch and let that go ahead and start doing its job of keeping those platelets from further sticking and worsening. Now, of course, beyond that, guys, our Brady system, if you want to know, let's look at a couple of our protocols because we got, like I said, we got two things going on with this person, right? Not only uh, do we have them at Brady, but we also have them at a STEMI, right? So let me see if I can pull up. Give me just 1 second, guys. My one of mine did not pull up. Let me pull this one up here. Did not transmit. So there we go. All right. So yeah, let's look at this bradycardia protocol that we have here. Because we know it's a STEMI. I mean, it's obvious, right? Like that's kind of a no-brainer, right? Like it's no question about that. Um, so let's zoom in a little bit. Let's kind of look at this. Um, so at the very top there, guys, you can kind of see that signs and symptoms, heart rate under 60, then, hypotension, QAMS, of course, they have chest pain, obviously, acute CHF, syncope, seizures, bradycardia, typically under 50, and we're at 42. So we know, right? So we have two branches, left or right. So to the right, you're going to see yes. So is the patient unstable? Absolutely. So what is some first things that we need to go and move to the patient, which is transcutaneous pacing, right? Let's go ahead and lay the pads to them. Let's go ahead and start pacing. Now it's going to suck for them, right? They don't have a blood pressure, therefore we can't really administer any sedatives. If they had a greater blood pressure than 90 systolic, then absolutely, that's perfectly fine. But this patient doesn't necessarily have that, so it's a priority for us to go ahead and lay those pacing pads to them. And I know that the question arises. So the person's already has a myocardial infarction and we're laying electricity to them, is that going to worsen it? Not to the extent it's already, because it's more of a vasal occlusion, right? And we're looking at the arteries clogged. So we're going to just try to stimulate that heart to perfuse a little bit more. Because the conduction path, we'll talk about that in just a minute as far as why is this patient presenting in such a way. All right, so electricity across the chest, right? So just know 70 beats per minute is completely acceptable. The thing that we see quite often is a lot of the paramedics out there like to set the milliamps really low. So people expect to get capture in the 80s and 90s, and that's not the case, guys. Typically, you're don't be surprised if you're up into the hundreds before you get mechanical capture, okay? And just remember, we'll go through the process of setting up that monitor to do transcutaneous pacing. Where are we trying to line up? How can we feel, we feel for a femoral pulse, which depends on who you talk to. Do they have a good, strong femoral pulse? You can also do radial, but I feel like something that's closer to the trunk, such as a femoral, is going to be a little bit better. So I would suggest to you that you move in that direction to fill. And it's a good idea to keep that hand on there. So whoever's putting the milliamps to it should be the one also filling. I feel like it's a better way to kind of assess and know if it's working or not. If you do find that it's working, different literature will tell you different things. A lot of times you get mechanical capture. It's completely acceptable to go 5 milliamps over. So if you get capture, say at 105, which I can't remember if that's even a range. We say 105. It's completely acceptable to go up and jump up to 110. That way it kind of maintains that mechanical capture. All right. So you have mechanical capture, and the person is, sitting there just thumping on the chest. You continue to reassess the vitals. You find that things are not working out very well. You're still having some issues with this patient. You also elect to, of course, get your bilateral IVs. You're also bolusing the patient as per your protocol. It says 500 to 200 liters because you know obviously their heart is not doing as it should. We know that this is a cardiogenic in nature as far as the shock is concerned. So we can add a little fluid to it, and hopefully that will help to fill the pipes a little bit more to offset the hypotension. So, of course, our goal essentially is going to be oxygen saturation needs to be above 94%. I think everybody understands that. So, as far as our pharmaceuticals are concerned, what do we have at our ready that we could potentially administer for our patient? I mean, it's obvious you have the right in front of you, you have the protocol. Atropine, okay? Now, atropine, we must know, guys, atropine is effective for only certain types. Now, if you have a second or third degree AV block, it's not going to work. It's not going to be effective. Now, this patient could potentially work well because we don't really see any blocks per se. So there's no disassociation between the P waves and the QRS. So you could potentially give this patient 1 milligram and then wait about 3 to 5 minutes and see if it works. So if you did not say that doesn't work, you're not having good effect with that. Say you max it out at the 3 milligrams, then we can move towards different medications, right? So you have your epinephrine, your epidrip, and also you have your dopamine. So your prerogative is going to be one or the other. It's going to be either of the two. So would you think that one would work a little bit better than the other in this situation? What do you think? I mean, I personally do believe this 100% that dopamine would be the better choice of the two. Now, the reason being, guys, is that works extremely well in cardiogenic shock. It works extremely well. Has great effects. So what happens is this patient will needs a vasopressor, but it also needs some type of entrope that helps to kind of stimulate the heart, and of course conotrope to be able to kind of squeeze and move the heart a little bit firmer, right? So this all works very well for this patient. Of course, our adjustment to try to get the correct dosage is going to depend on how their blood pressure titrates to. So, where our aim is always going to be above 90 systolic. So, if you guys want to start about the 10 range, there's nothing wrong with that. That's completely okay. But just know that you need to keep a really good eye as far as where how it's becoming effective there. Okay. So all right, so you have that on board, guys. I'm going to go ahead and let you guys look at the Pearl side of that while I'm discussing some other things. So, as far as your goals, what would you say your goals, your aim would be for this patient ultimately? Um, your goals, your aim essentially is going to be that you get there and that you actually have that you get them to definitive care always, right? We need to get that mechanical capture and maintain that. Um, if those prove not to be effective, we need to move to a pharmaceutical. So dopamine would be best for this situation. And of course, airway maneuvers. If you need to do, BVM, if you must ventilate, that's always the thing that you could potentially do. Fluid boluses, EKG transmission also is going to be something that you can do too. All right, so there you go. So that's the down and dirty to this scenario. Now, listen, one thing that's very important about this is knowing that atropine is not always effective, guys. Even for these bradycardic, symptomatic bradycardic patients, you're not always going to be able to hit and actually get something that works well. So don't be surprised if you give atropine and things don't work. It only actually works 20% of the time, okay? Or 28% of the time. So here's your going back to it, guys, here's your different effects and everything as far as the bradycardia, we're gonna phosphate, but we're focusing more for this. Now, I don't know why it says if endotracheal. That's something I guess we need to remove. We don't do anything through the tube anymore. Okay. So also let's also look at I'm recording this for y'all. Let's also look at some other. So let's see your epi drip here, guys. It'll come up. There we go. Okay, so here's your epi drip, guys. If I can get it to work, hold on. All right, epi drip, like I said, now this is still a good vasopressor. I mean, it really is an excellent vasopressor, and also does have some intratropes onto the heart, so it does work. Now it's 2 to 10 micrograms for this, which fairly efficient, does fairly well. But my choice, especially for a STEMI, is going to be your dopamine. That's going to be your way to go. So let me pull up the dopamine right quick. So you guys have that. Heck, get this thing to work. Oh, guys, of course I can't find it. Let me re-download it. Thought I had everything ready to go. That's okay. Just pull up your protocol book, guys, and just look at dopamine. Make sure you're familiar with that. Okay, some other information. Most patients are more responsive to epinephrine over atropine, by the way, just to let you know, just because epinephrine has a tendency to kind of hit um, all the different um, myocardium. So it goes for the atria, the SA node, the AV node, the ventricles, everything. So that's why it's very, very effective. So if you have something that's kind of shut down and you can tell that we're getting into some junctional rhythms and such, that could potentially be your go-to for that kind of situation. All right. So why in the world is the person showing a super Brady in the presence of an inferior MI? What's interesting, guys, is inferior MIs are probably one of the most common types, and you guys probably have seen this across the board. It's probably one of the most common types of STEMIs that you see. Most common. It accounts for approximately 50% of the calls that you have. And what's also very interesting, the RCA supplies the AV node. So where your AV nodes, if it goes and it cuts off that fluid or the blood flow to the AV node, of course you're going to start leading into a more of a bradycardic rhythm. So that's where we see this most of the time. So they also say that 90% of the complete AV cases are acute inferior wall MIs. Which occurs right at the bone of the his, and that starts causing all those different types of weird rhythms, including those junctional rhythms. So if this person's already showing signs of shock, we're going to consider this as a bradycardic peri-arrest. That person is going to eventually worsen and deteriorate to the point where they could potentially die. Going to be that's downward spiral, right? That's where it's going to be of great concern. So important that we're aggressive with this patient. We get them the treatments that they need to get them lined up and get them going. Okay, guys? All right, so that's all I have for y'all. If you have any questions concerning this, let me know. And like I said, we'll meet up with you guys, and we will most definitely be able to we'll get up with y'all as far as your skills are concerned. Okay. All right, guys. I hope you have a wonderful day. Thank you so much for hopping on. Take care.